Orthopedics is one of the most financially complex specialties in American medicine. You are executing high-value, highly demanding clinical procedures, but those procedures are colliding with intense, unforgiving payer rules. You can have a packed schedule and high surgical volume, but if your billing office is struggling with thin margins and a growing pile of denied claims, your practice is bleeding money. This is a structural problem, not a staffing problem. Claim denial rates hit 11.8. For a practice handling a couple thousand denials a year, you are spending hundreds of thousands of dollars just to chase revenue you already earned. A single modifier applied incorrectly or a small coding inconsistency in the billing department eventually compounds into a massive six-figure threat to your practice's survival. The friction starts before the patient even reaches the operating room. Physicians and their staff now spend an average of 13 hours every single week completing prior authorization paperwork instead of focusing on patient care. Orthopedic ambulatory surgery centers are hit particularly hard. Right now, 92% of orthopedic ASC claims require pre-authorization, and insurance companies are leveraging AI to automate their claim reviews. If an algorithm flags a specific documentation gap on one claim, it instantly flags that identical pattern across all your future claims. Add in the 2026 Medicare Physician Fee Schedule, which applied a negative 2.5% efficiency adjustment to orthopedic surgical work RVUs. Every percentage point of uncollected revenue costs you more today than it did last year. Asking a stressed back office team to work harder and manually submit claims is a losing strategy when the entire payer ecosystem is technologically engineered to delay and deny complex procedures automatically. The default reactions of most practices is to hire more front desk staff, but treating a complex clinical coding deficit as a generic staffing problem ignores the root cause. This chart maps the reality of orthopedic billing. The specialty utilizes over 500 CPT codes for surgical procedures alone. You need precise application of global surgical package modifiers, rules for modifiers like -78, -50, and -59 to get paid correctly. Practices that rely on staff to make case-by-case modifier judgments produce denial rates 3 to 5 times higher than practices operating with embedded, specialty-specific protocols. Maintaining an in-house model carries immense financial friction. A single fully loaded billing specialist costs between $55,000 and $75,000 a year before you even factor in benefits or training time. Then there is the operational vulnerability of turnover. Replacing just one frontline support member costs between $25,000 and $30,000, and it resets your entire training clock to zero. When a seat sits empty, claims go unprocessed. Because of these internal staffing constraints, 50 to 65% of denied claims are never worked on at all. Relying on a generic in-house staff to fight a highly specialized AI-driven payer system guarantees you high fixed overhead and deteriorating collection results. A growing number of practices are replacing the traditional staffing model entirely by syncing an outsourced, specialty-trained partner into their existing operations. This is structured as embedded support. Instead of logging into disconnected external portals, the dedicated team works directly inside your practice's existing EMR every single day to clear the billing queue. Clinical credentialing makes this possible. Every team member holds AAPC and AHIMA certifications, guaranteeing they have the specialty-level training required for precise ICD-10 specificity and complex modifier interpretation. Staffingly provides these dedicated, credentialed orthopedic teams at a flat rate of $399 per week per seat. This graph contrasts the two approaches. It pits the highly volatile, jagged costs of in-house staffing and turnover against a predictable flat rate, showing how this model converts massive fixed overhead into a scalable, controllable cost. Because they operate within your systems, strict data security is mandatory. The infrastructure is protected by SOC 2 Type 2, ISO 27001, and HITRUST certifications with HIPAA-compliant encrypted connections. Staffingly also augments this specialized human workforce with AI-driven tools. Their automated claim scrubbing processes catch between 70 and 85% of common errors prior to submission. Embedded credentialed outsourcing secures a clinical-grade financial infrastructure that generalists simply cannot provide. The primary hesitation for any practice leader is the fear of operational downtime, communication friction, or losing control during the transition to a new billing model. To solve this, the transition runs on a strict 14-day go-live window. EMR access, team training, and protocol setups finish within 2 weeks. You are assigned a single dedicated coordinator as your primary contact, eliminating administrative bottlenecks and streamlining communication. Your CFO and COO receive a weekly KPI dashboard, giving you total transparency into claim throughput, coding accuracy, and direct return on investment. After the pilot, the engagement operates on a flexible month-to-month basis. You can scale the team up, scale it down, or replace team members within 48 hours. This highly structured integration process shifts the practice manager's role away from policing daily billing tasks and toward managing high-level financial outcomes. When you look at the final evaluation of these two strategies, the traditional in-house model becomes mathematically and operationally indefensible for most orthopedic practices. This matrix table breaks down the baseline costs side by side. You are comparing the $55,000 plus annual burden of a single in-house FTE against the approximate $20,748 annual rate for a fully credentialed Staffingly seat. This $35,000 to $54,000 difference per position represents direct profit flowing back to your bottom line. Staffingly has built a track record proving this works, serving over 800 healthcare providers and generating more than $14 million in combined administrative cost savings. If your practice has zero turnover and a tiny denial rate, you might not need this. But if you run a high-volume clinic bleeding margin to modifier errors and prior authorization delays, this model was built for you. For modern orthopedic practices, transitioning to an embedded, credentialed billing team is a critical revenue protection strategy. Secure your practice's operational future. Start your 30-day free trial at staffingly.com/demo.